Hello everyone. I am Docsaab and today we will be diving into a crucial tool in breast imaging, the breast imaging reporting and data system or BI-RADS. This system is fundamental for anyone involved in breast health, from medical students learning the basics to experienced doctors managing complex cases. Let's begin with the essentials. What exactly is BI-RADS? At its core, BI-RADS is a standardized quality assurance tool meticulously developed by the American College of Radiology. Its primary function is to create a universal language for reporting breast imaging findings. This system isn't new. Its history and evolution dates back to its inception in 1993, initially focusing on mammography. Over the years, it has continuously evolved through multiple editions, with the fifth edition being the current standard, expanding to include lexicons for ultrasound and MRI. This constant refinement ensures it remains relevant with the advancements in imaging technology. The purpose and importance of BI-RADS cannot be overstated. Firstly, it standardized terminology, eradicating ambiguity and fostering clearer communication among radiologists, referring clinicians, and other members of the healthcare team. This standardization reduces inter-observer variability and helps prevent misinterpretations. Secondly, it serves as a robust tool for outcomes monitoring and research, allowing for consistent data collection that informs clinical guidelines and advances our understanding of breast cancer. Our target audience today, comprised of medical students and doctors, will find this system indispensable for accurate diagnosis, effective communications, and optimal patient management in the realm of breast imaging. The heart of the BI-RADS system lies in its numerical assessment categories ranging from 0 to 6. These categories are assigned to every breast imaging study and are crucial for communicating the level of suspicion for malignancy and guiding subsequent clinical management. Let's quickly review them. BI-RADS 0 signifies an incomplete assessment, meaning that more imaging or information is required. BI-RADS 1 means negative, indicating no abnormal findings. BI-RADS 2 indicates a benign finding where an abnormality is present but definitely non-cancerous. BI-RADS 3 is for probably benign finding with a very low likelihood of malignancy but requiring a short-term follow-up. BI-RADS 4 denotes a suspicious abnormality indicating a need for biopsy to determine the nature of the lesion. BI-RADS 5 is assigned when findings are highly suggestive of malignancy with a very high probability of cancer. And finally, BI-RADS 6 is used for a non-biopsy proven malignancy, typically for monitoring purposes before definitive treatment. Each of these categories carries a specific clinical implications and dictates the next steps in patient care, ensuring a structured and evidence-based approach to breast health. Let's dive into BI-RADS 0. The definition and clinical context of BI-RADS 0 is an incomplete assessment. This means the radiologist cannot make a definitive assessment about whether finding is benign or malignant with the images currently available. There are several reasons for an incomplete assessment. It could be due to technical factors such as suboptimal image quality, dense breast tissue obscuring a potential lesion, or the need for additional specialized views like magnification views or spot compression. Often, it is assigned when a finding on screening mammogram requires further workup, such as diagnostic mammogram or an ultrasound, for a clearer evaluation. Comparison with prior examination might also be unavailable or insufficient. The next steps and recommendation for BI-RADS 0 assessment are crucial. It mandates that additional imaging or comparison with previous studies be performed. This is not a final category. Rather, it is an interim assessment prompting further investigation to allow the radiologist to assign a definitive BI-RADS category from 1 to 6. It is important to communicate this clearly to patients, explaining that it means more information needed rather than something being necessarily wrong. Moving to the reassuring end of the BI-RADS spectrum, we have categories 1 and 2. BI-RADS 1, no abnormality detected. This is excellent news for the patient. It means the breast tissue appears completely normal and symmetrical on imaging with no masses, architectural distortions, or suspicious calcification identified. The breasts are essentially clear and the risk of cancer is considered extremely low. BI-RADS 2, clearly benign findings. In this category, an abnormality is present but is unequivocally non-cancerous. Examples include simple cyst, which are fluid-filled sacs, benign calcification, which have specific non-suspicious shapes, and distributions, fat-containing lesions such as lipomas or oil cyst, or intramammary lymph nodes, which are normal lymph nodes located within the breast tissue. While these findings are described in the report, they pose no malignant threat. The clinical implications and follow-up for both BI-RADS 1 and 2 are typically the same. Routine annual screening, mammography, or other appropriate age-based screening. No further immediate action is required. However, it is important to remember that if a patient has a palpable lump but the imaging report is BI-RADS 1 or 2, clinical follow-up of the palpable finding is still warranted, as imaging cannot always entirely rule out of all concerns. These categories provide significant reassurance to both patients and their healthcare providers. BI-RADS 3 is a nuanced category that often requires careful management and patient communication. It designates a probably benign finding, meaning there is a very low but not zero probability of a malignancy, typically less than 2%. Distinctive and imaging features that fall into BI-RADS 3 include non-palpable, circumscribed solid masses on initial imaging studies that are deemed benign in appearance, or certain types of clustered round calcifications. Specific types of focal asymmetry or single lobe fibroadenomas that have been stable for a long time may also sometimes fall into this category. The radiologist must be confident in its benign appearance, but it doesn't meet the strict criteria for BI-RADS 2 designation. The malignancy risk assessment for BI-RADS 3 is deliberately low to avoid unnecessary biopsies for lesions that are highly likely benign. However, this low risk necessitates careful monitoring. The primary management strategy is short interval follow-up, typically at 6-month interval for 1 to 2 years, using the same imaging modality that identified the finding. The goal is to observe the stability of the lesions over time. If the finding remains stable, it can then be downgraded to BI-RADS 2. If it grows or changes its morphology, it will then be upgraded to BI-RADS 4, prompting a biopsy. Patient counseling is absolutely vital for BI-RADS 3. It is crucial to explain to the patient that while the finding is most likely benign, this short-term follow-up is a conservative approach to ensure complete safety and to catch any rare instances of subtle malignancy early. Reassure them that this strategy minimizes invasive procedures while still maintaining vigilance. This balanced approach is key to managing anxiety and ensuring patient adherence to the follow-up schedule. Moving up the ladder of suspicion, we arrive at BI-RADS 4, suspicious abnormality. This category indicates a significant concern for malignancy and almost always warrants a tissue biopsy to establish a definitive diagnosis. BI-RADS 4 is further divided into three subcategories, reflecting increasing levels of suspicion for cancer. 4A, low suspicion. This subcategory carries a 2 to 10% of probability of malignancy. Findings here are concerning but not classic for cancer. Examples might include a partially circumscribed solid mass that's probably benign but not definitely so, or a cluster of amorphous calcification that aren't clearly benign. 4B, intermediate suspicion with a 10 to 50% chance of malignancy. This subcategory includes a finding with features that are neither clearly benign nor clearly malignant. A good example is an oval mass with slightly irregular margins or fine pleomorphic calcifications. 4C, high suspicion. This subcategory signifies a 50 to 95% of probability of malignancy. These findings have some but not all of the characteristics features of cancer. This could be an ill-defined or irregular mass or a neopleomorphic or linear branching calcification that are highly suspicious but still fall short of the definitive malignant appearance of BI-RADS 5 lesion. Specific imaging findings for BI-RADS 4 can therefore vary widely but generally include new or enlarging masses with irregular or indistinct margins, new or changing clustered microcalcifications, or architectural distortion without a clear mass. The malignancy probabilities associated with each subcategory are crucial for guiding clinical judgment and prioritizing follow-up. For all BI-RADS 4 lesions, biopsy recommendations are the standard of care. The method of biopsy, such as core needle biopsy, vacuum assisted biopsy, will depend on the imaging modality used to visualize the lesion and its specific characteristics. The goal is to obtain tissue for pathological evaluation to determine if the lesion is benign, high risk, or malignant. When a radiologist assigns BI-RADS 5, it is a very serious finding. This category signifies that the lesion is highly suggestive of malignancy with a probability of cancer exceeding 95%. These are the findings that scream cancer on imaging. The imaging hallmark of malignancy in BI-RADS 5 are typically classic and undeniable. They include spiculated masses which have sharp radiating lines extending from the lesion, highly irregular or stellate masses with associated architectural distortion, and specific types of calcification such as fine, linear, or branching calcification that follow a ductal distribution. Given the very high probability of cancer, the immediate next steps are urgent biopsy and treatment planning. A tissue biopsy is essential to confirm the diagnosis, determine the specific type of cancer, and assess its biological characteristics. Even in the rare instance that a biopsy yields a benign result for a BI-RADS 5 lesion, a surgical consultation is strongly recommended. This because such discrepancy between the highly suspicious imaging and a benign pathology known as radiologic pathologic discordance warrants a further investigation obtained with surgical excision to ensure no malignancy was missed. This category demands prompt and decisive action to initiate the appropriate oncology pathway. Our final category is BI-RADS 6, non-biopsy proven malignancy. This category is unique because it's applied only when a biopsy has already confirmed the presence of cancer, but the patient has not yet undergone definitive treatment such as surgery or radiation. The primary role in treatment monitoring for BI-RADS 6 is to evaluate the response of the known cancer to new adjuvant therapy, that is chemotherapy or hormonal therapy given before surgery. Imaging studies are performed to track changes in the size and specific of the tumor, helping clinicians assess the effectiveness of the preoperative treatment. It is also crucial for preoperative staging. Even with known malignancy, imaging reports using BI-RADS 6 contribute to the overall staging of the disease, providing vital information for surgical planning and determining the extent of the disease before surgery. The implications for imaging reports in this category include a clear statement of the known malignancy, usually referencing the biopsy date and pathology report. The report will then describe the current appearance of the lesion, noting any changes in size, shape, or extent which are critical for guiding the oncology team. It is important to differentiate this from a patient with a history of treated breast cancer who is now undergoing routine surveillance. Such a patient will typically receive a BI-RADS 1 or 2 if no new suspicious findings are present. Beyond just categorization, BI-RADS profoundly impacts clinical practice, fostering an essential interdisciplinary approach to breast care. Effective communication with patients and clinicians is paramount. While BI-RADS is a technical language for medical professionals, its results must be translated into clear, understandable terms for patients. This often involves detailed discussions and providing patient-friendly summaries such as lay letter explaining the results and next steps. For example, a BI-RADS 0 might be explained as we need a few more pictures to get a complete look. Responsible reporting minimizes patient anxiety and ensure informed decision making. BI-RADS reports directly impact treatment decisions. The assigned category guides whether a patient needs further imaging, short-term follow-up, biopsy, or immediate referral to an oncologist or surgeon. This structured approach helps in avoiding unnecessary procedures while ensuring that suspicious lesions are thoroughly investigated without a delay. The role of multidisciplinary team is significantly enhanced by BI-RADS. Radiologists, breast surgeons, medical oncologists, pathologists, and radiation oncologists all speak the same BI-RADS language, facilitating seamless collaboration. When a radiologist assigns a BI-RADS 4 or 5, for instance, the entire team understands the urgency and potential implications, allowing for swift and coordinated patient management. We often utilize case studies and examples in teaching to illustrate how different BI-RADS categories translate into real-world scenarios, demonstrating the clinical reasoning behind each assessment and the subsequent management recommendations. This practical application reinforces the importance of responsible BI-RADS reporting and its direct impact on patient outcomes. In conclusion, the BI-RADS system is indispensable. Its standardization and reproducibility ensure consistent reporting across different institutions and providers, which is vital for both clinical practice and research. By minimizing both overutilization and underutilization of follow-up tests and procedures, BI-RADS plays a significant role in improving patient outcomes. It allows for clear communication of the likelihood of malignancy and guides appropriate management, ultimately leading to better and more timely care. Thank you for your attention, guys. If you have any further questions, please feel free to reach out to me via comments or DM me on Instagram. And please like, share, and subscribe to the Docsaab's Diary.